Amburajan sir. Amburajan sir, you can begin.
Can you hear me?
Yes.
Okay.
Dr. Jaydev, shall we start?
Yes, yes.
Yes. Sir, on behalf of IMA College of General Practitioners and Synapse Brain and Spine Foundation, I invite all those who have come for this series of online lecture on understanding brain and spine problems for primary care physicians. Last week we had a very interesting, topic on low back pain and disc prolapse. It was being, attended by a lot of our general practitioners, and the interaction itself was very interesting that so many people got, involved into it, and the presentation was so, easy to understand, and what the examples that was given was very, useful for all the attendees. Today we are here to learn about sciatica and neurogenic claudication. So the speaker, Dr. Jayadev Panchwak, he is a neurosurgeon and brain and spine surgeon and founder member of Neurologist Indian Indo-German Neurosurgery Foundation. So though he is having a lot of experience and very earnest person in the field of neurosurgery, but he has made himself down up to the level of our general practitioners and was explaining about the neurological problems very simple way. So I have been attracted by the way he was presenting in the last week. So we are very eager to hear about the next topic, the sciatica and neurogenic claudication. And we welcome all those who have joined in this from different parts of this country. And I also welcome our Dean, Dr. Avinash Bande, who has been very much instrumental in organizing such kind of programs very regularly for the benefit of general practitioners. And I also welcome Dr. Patil Sanjay and Dr. Rekha Madam, who have been in the panel list. So we are going to have a very interesting session today. Before that, I request our Dean, Dr. Avinash Bande, to give his remarks on this today's topic. Dr. Avinash.
Yeah, thank you, Dr. Amarajan sir. On behalf of IMA CGP headquarters, we welcome you all our office bearers, Dr. Anbarasu, Dr. Amurajan, Dr. Rekha, Dr. Sanjay Patil, and of course today's speaker, Dr. Jayadev Panchwak. Last time we had very excellent, interesting session, and now this is to be the next part of that lecture. So no need to talk much about it. I think that was the first lecture was very, very impressive and very, very interesting, and definitely useful for all of us in our day-to-day practice. And I'm sure Dr. Jayadev Panchwak will repeat this performance in every lecture of it. And I think instead of talking too much, I request Dr. Jayadev Panchwak sir to begin his speech. Thank you.
Thank you. I want to share the screen now.
They have made you host. They have made you co-host. Must be.
Yeah. Can you see the screen?
No, sir.
It's not seen, sir.
Okay.
The screen is not visible. Not visible.
Okay, I will share it again.
Yeah.
Now it is visible.
Yes, sir. It's
No,
coming.
it is.
Sir.
Yes, sir. Yes.
Very good. Sir.
Yes.
Now it is seen, sir.
Yeah. I
Okay,
request
thank you.
our IT coordinator to mute all except for the speaker.
So, good evening, everyone. Last time we discussed about back pain, low back pain, especially. As we all know, it is a very, very common problem. Low back pain gives rise to many other problems in some people, and they are also very common. Like sciatica is the problem that we see almost every week. 3 or 4 patients, I'm sure in general practice, you must be seeing people having pain in the low back, which is radiating to one of the legs. The reasons or the diagnosis may be different, but the complaint remains the same. So last time we saw which back pains should be taken seriously. And let us recapitulate that. Any back pain which has history of recent trauma or not relieved by rest, awakens at night, or causes weight loss or fever, or it is rapidly increasing in intensity. There is history of cancer in that patient. There is bladder involvement, bowel involvement. There are sexual symptoms, or there is radiation or spreading of pain in other areas. Now we are going to focus on this particular red flag today, and that constitutes sciatica and neurogenic claudication. Though we know the word sciatica, it is very important to understand the word neurogenic claudication very, very carefully. So back pain leading to a radiating pain, typically called as sciatica. And whenever there is compression in this area, that is the lumbar area, one of the 4 symptoms happen, or more than one can also happen at the same time. Low back pain, sciatica, neurogenic claudication, and CAUDA equina syndrome. So we will look at them one by one. So sciatica typically starts from low back and then goes in the buttock, either in the posterior aspect or on the side, and then goes in the posterior aspect of the thigh and then to the calf. So this is a typical sciatic pain that we know of. As we all know, this pain can also go laterally and slightly anteriorly in the thigh and in the leg, as we will shortly see. So depending on which lumbar root is involved, the radiation of pain changes. The first is, of course, the typical S1 sciatica, or pain along the sciatic nerve. That's how the name has come. And these are other root problems. So any patient who comes with a pain symptom, which is radiating pain to the lower limb, has to be clinically approached as pain in the lower limb and not labeled as spinal sciatica, because there are some other mimics like cervical myelopathy or hip joint problems, sacroiliac joint problems, peripheral nerve entrapments, peripheral neuropathies, or vascular claudication. So rather than assuming this pain is because of a nerve getting pinched, first we have to quickly rule out these things when examining the sciatica. Once we have done that, then the disc-related sciatica remains, and the clinical presentations of this sciatica are, that is disc-related sciatica, are of 2 main types. The first is acute sciatica. The first is, of course, only low back pain due to disc prolapse, but when sciatica starts, The first type is acute sciatica. And in this, the patient tells us that he was fine, but while lifting something heavy or playing a strenuous game or cycling or during some strenuous activity, there was sudden shooting pain which has started in the low back and then spreading in the thigh and calf. So this is what is called as acute sciatica. That is, it was not there before. Chronic sciatica is much more common. So these people have had disc prolapse or nerve root pinching because of something else for a long time, and these people come time and again with complaints of pain that is radiating to the lower limb. In between, the pain reduces. Again, due to some activity, the pain increases. So this is called as chronic sciatica. So it is continuous or frequently intermittent radiculopathy. And the fourth problem is the CAUDA syndrome, which should never happen if we take care of these two problems. We will speak about CAUDA syndrome as we go along this lecture. So in acute disc prolapse, there is severe radicular pain, the first type I'm describing, but there is no motor or bladder deficit. The second type is severe radicular pain, that is pain going in the leg, only mild motor deficit. The person says that there is some weakness in the foot, and if you examine that person, you will realize that there is some weakness in dorsiflexion. And the third type is pain with bladder deficit or severe motor compromise. Now, these three things can happen in acute setting. This is a slide which I had shown last time, and I'm repeating here. This is the central portion of the nucleus in an intact disc, and this is annulus fibrosus, a tough membrane around the nucleus. The disc is not a vascular structure, and only its anterior portion is innervated by sensory nerves. So when there is a tear in the annulus fibrosus, the disc starts coming out and inflammatory changes happen and pain starts. This pain is initially, as I had told you, it is a low back pain, but as the disc prolapses further and starts contacting the nerve root, because of the inflammation, that is the antigenic properties of the disc material, the pain starts. And as the disc herniation progresses, the pinch, mechanical pinch increases and the radiculopathy or sciatica starts. So this is again the same picture last time we had seen. This is the first stage of disc prolapse, and finally the disc comes out and compresses the nerve here. So depending on which nerve it compresses, the pain radiation pattern is seen. Now this pattern, that is the posterior part of the buttock, posterior part of the thigh and calf, finally radiating to the outer part of the foot and the little toe. This is typically S1 root compromise. Now S1 root compromise classically occurs in L5-S1 distribution disc prolapse. L5 root pain is slightly anterior, that is on the lateral part of the thigh, again lateral part of the calf, lateral and posterior junction, and it typically radiates in the first two toes of the foot. L4 root pain is further anterior, and it comes to the anterolateral part of the thigh and then goes on the shin. And L3 root pain is only up to the knee. Some people with knee pain who don't have any knee problem can have L3 root pain, and this pain is a radiating pain which is coming anterior like this. L2 radiculopathy is very rare, but if it happens, then it is towards the medial aspect of the thigh, but it is very, very uncommon. So when the disc starts herniating, the first stage is disc herniation and internal disc prolapse, that is prolapse within the disc material. Then the nucleus comes out through the annulus fibrosus, and then we call it as prolapse. then some portion comes out and pinches off from the basic nucleus, and it is called as extrusion. And this extrusion can remain either at the same site or it can move up or down, and it is called as migration. So extrusion with migration of the disc fragment. And then sequestration. Sequestration is when the disc fragment remains there for a long time, and because of the inflammatory reaction, it becomes a tough structure. It becomes a sequestrum. And that is one of the dangers of conserving some of the discs with alternative medicine. That is, if this disc fragment has invaded the root and becomes a sequestrum, then there are permanent changes in the root. So one has to be very careful when one is delaying surgery. Initially, the treatment is obviously conservative, but if the conservative treatment is not helping, then one has to, be very careful and take decisions in time. So this is an example of extruded disc. This patient came to me with sudden onset pain, that is radicular pain, but on asking history carefully, he admitted that there was back pain. So if you see here carefully, this is a nucleus pulposus, white in color, which is herniating out, and this prolapse was there, must have been there for a long time. And when he bent down, this portion of the disc came out and then left its place and became an extruded fragment. He was in severe pain, and this is a large disc fragment, nearly 3.5 to 4 centimeters in size, as you can see here after microscopic discectomy. Now, sometimes there is extrusion and migration. As you can see here, this disc has come out. So there's extrusion, but it has also migrated down. So this is a piece of the disc which has migrated down. And if you see carefully, there is a root on this side, and this root is engulfed by this disc piece. So this is extrusion and migration. Migration without sequestration. So this remains attached partly. So there is migration, but there's some part attachment. So it doesn't become a sequestrum. And you can see this being removed in small pieces here. This person came with a very similar picture, scan picture, and he came with left-sided severe sciatica. And you can see a fragment of the disc in the spinal canal here. So this is the disc, L5S1 disc, which has come out, and it is compressing the nerve root here. So it needed early surgery. Sometimes sciatica can happen because of posterior compression. That is, the posterior ligament becomes calcified. Though there is a small disc, the disc itself is not causing any compression. It is just helping the compression, take the final shape of this element causing severe sciatica. So this is a black shadow, which you can see. This is large calcification in the ligamentum flavum. It is part of the process of spondylosis. That is, in some people, as I told you last time, the spondylosis becomes too much, and then such things happen. And this is what we see here. This is an example of a person who came to us with chronic disc herniation. For a 3 years period, he was having off and on pain, and he was just suffering in between. In between, his pain used to disappear, so he was being conserved outside. But his life quality had deteriorated significantly, and we had to treat this surgically. But this is an example of chronic disc herniation at 2 levels here. Now, sometimes, as I told you last time, the canal in the lumbar area is narrow from birth. It is called as congenital lumbar canal stenosis. Now, if in such scenario, this background, you get a disc herniation, then even a small disc herniation like this can cause very, very severe kind of compression. As you can see, this is the spinal canal, and these are the nerve roots here. And here you see this portion is causing severe compression on the nerves. So this is another example. Now, this is an example of how a prolapsed disc, which is not treated for a long time and is treated conservatively by alternative therapies and various other methods and magnets and whatnot. In some people, this portion of the disc, which is prolapse, can become calcified, and when it becomes calcified, it can stick to the root, the nerve root, and cause severe pain. And during surgery, it is very difficult then to separate it from the nerve root. So you can see this periphery, which is calcified, almost become a bone. And this root, we had to operate under microscope for a longer time than usual to separate it from the root and remove it completely. So this is something one has to remember. I'm not saying that it happens every time, but this possibility has to be borne in mind if the symptoms do not go away with conservative treatment. Now, this is an example of massive disc prolapse. As you can see here, there's a big disc prolapse, and such disc prolapse, if it happens, now luckily in this person, the canal size, as you can see, this is a white CSF shadow. It's a very wide canal. So this big disc, massive disc, is not causing complete blockage of the canal. It did cause severe sciatica, and we had to remove this fragment by endoscopy. But if this canal was smaller in this particular person, then this disc would have caused severe damage to the nerve roots. So this is the importance of knowing how in each person the diameter of the canal varies. So radiological report of disc prolapse or size of the disc has to be seen on the background of clinical presentation. Again, this is an example of large soft disc prolapse. This is again a central disc prolapse, huge disc prolapse. This fragment was removed endoscopically, and you can see a large fragment removed from this portion. So L1-2 is a very rare level, for disc prolapse, and in this particular person, you can see that this disc has indeed prolapsed. We have seen a few discs like this, L1-2, and less commonly T12L1. Though they are uncommon, they are not unknown. So just a minute, just give me a minute, because I think I have to. Is it okay now?
Yes, sir. Go ahead.
Okay now? Okay.
Yes, sir.
So this was a large central disc prolapse I showed you. And then this is L1, L2 disc prolapse. This is D12, L1 level disc prolapse. This is a large disc prolapse here. As you can see, this is D12 and this is L1, uncommon levels. In such cases, sometimes because we have to drill the facet, we have to fix on one side after removal of the disc. Now, this is, though it is looking like a big disc, this is actually the ossification or calcification of ligamentum flavum. And disc is very small here. There's a predominantly posterior compression. And you need not remove the disc in such cases. Just drill it carefully by, saving the nerve roots very carefully. This is an example again of extreme canal stenosis. There is an entity called lateral gutter stenosis. And what is it? The nerve root, which is leaving the lumbar canal, just before leaving the lumbar canal, it lies in a gutter that is known as a lateral gutter. And because of the facet joint hypertrophy, this root gets compressed in this gutter. So it is not because of the disc, but because of the bony outgrowth. And this is called as lateral gutter stenosis. And this presents just like sciatica. But in this case, there is usually pain on extension of the back rather than flexion. So this is one relative differentiating feature. Now, about discectomy, there are two important types of discectomies. The first is microdiscectomy, which is done with the help of microscope, and in which we take a very small incision and under microscopic magnification, we remove the disc. Now, this is a gold standard when the results are compared. Microdiscectomy results are always compared with the newer modalities. And microdiscectomy is very useful because the area just around the root is extremely important. And there are many blood vessels and adhesions around this. So to decompress it completely, the use of microscope makes a huge difference. The other type is, of course, endoscopic resection of the disc. I showed you a video very rapidly last time. Perhaps I can show you in detail. This is a endoscopic resection. The incision is not in the midline. There is midline endoscopy also, but what I'm talking about is a lateral endoscopy. So you do not disturb the spinal canal at all. You go laterally like this and in the disc prolapse and remove the portion of the disc that is prolapsed. So this is what the microscopic, that is posterolateral microscopic discectomy looks like. This is a piece that is removed. In microscopic discectomy, the area between two vertebrae is made use of. There is a natural window between two vertebrae. And this window is slightly widened. No part of the vertebra is resected. Microscope is brought in and the root is visualized. And then after retracting the root, the disc is removed. So this is the basic principle of microscopy. You do not disturb spinal column too much at all. Just nibble the edge and remove the disc. So correct surgery selection is the key to success. So not all patients can be operated endoscopically. That is what one has to remember. To insist that all patients can be operated by endoscopy is a sure shot way to ensure failure, because one has to take into account multiple factors while selecting the surgery. And in any case, microscopic surgery is not that invasive at all. So this is how the microscopic discectomy looks like. The incision is about inch, inch and a half. And what I want to show is the adhesions which have occurred around the root. This is an thecal sac, and this is a nerve root. And in between the two, there is a disc. Yellow thing is a disc. This is a disc prolapse. But what I want you to see is these are the adhesions, you know. So the root is surrounded by the adhesions. So why these adhesions have happened? Because the disc that has prolapsed has got antigenic properties, and that gives rise to a lot of inflammation and adhesion. So just removing the disc sometimes is not enough. One has to release the adhesions also to treat the sciatica completely. So this is the disc fragment being removed under microscope. So this is how the microscopic discectomy looks like. In the end, the root is completely decompressed and there are two sutures. So this is what microscopic discectomy looks like. Endoscopic discectomy, I showed you this last time. I will show you the method in more detail this time. So this is the disc prolapse.
Now, this pain is there for a long time, maybe 3 to 4 years, and he has developed with the help
And
this
it's under local anesthesia. We put a needle inside and position it correctly at the place where the disc has prolapsed. Okay, now this is done completely under local anesthesia. And then there is sequential dilatation that happens over the needle, and the scope, which has got continuous irrigation, goes inside and it directly lands on the place where the disc has prolapsed. And you see the disc material here, and this disc that is prolapsed is being removed, and the remaining part of the disc is not disturbed at all. Only the portion which is prolapsed is removed. And this is the fragment of the disc. And now, after the removal of the compression, the nerve root is now pulsating very freely. And important thing, as I showed you, is this: only the prolapsed disc portion is removed. And within 20 minutes, the person is allowed to walk, and the person can be discharged within 1.5 to 2 hours. So this is the advantage of endoscopic discectomy. But I mean, not all discs can be removed by this method. So just because endoscopy is available, to subject all the discs to this kind of treatment is not correct. So that is what one has to remember. Now we come to the next topic, and that is lumbar canal stenosis. And I think it is a very important topic because I see a lot of the times this diagnosis missed by the practitioners for a long time, and the symptoms are blamed on varicose veins or old age or some other problems in the lower limb. But this is a very typical kind of set of symptoms. So please listen carefully to this. Now, spinal stenosis. First, let us see the normal MRI. Normal MRI, on this left side, you can see normal MRI. These are the discs between the vertebrae, and the white shadow you see is a CSF in the spinal canal. So this is a normal spinal canal, normal size spinal canal. Inside you see small gray threads. These are the nerves. So this is the spinal canal, and the nerves are within the lumbar spinal canal. So the diameter of this canal is very important for the health of these nerves which are passing through it. If because of disc prolapse or in addition calcification, spondylosis, or some other pathology like listhesis, that is one vertebra slipping over the other, this canal is compressed, then the nerves also get mechanically compressed, and the blood vessels which are supplying these nerves cannot bring the required amount of oxygen to these nerves. So these people tell you that this is an example of canal stenosis. This is a normal canal, and here you can see up to here the canal is all right, but up to here the canal is all right, but here there is severe stenosis of the canal. So these people tell you that I could walk maybe 2, 3, 4, 5 kilometers some months back, but now I can't walk more than 1 kilometer, because after 1 kilometer I start getting numbness, heaviness in the lower limbs, and after some time this distance reduces. This is called as claudication distance, and they say that I can only walk for 15 minutes, then 10 minutes, then 5 minutes. So this is how this claudication distance goes on reducing as the compression on the spinal canal goes on increasing. So it is very important to identify this symptom complex and in time intervene, rather than making a mistake of diagnosing this as pain due to old age or some other reason, because this is a correctable problem, and this happens most commonly in 5th, 6th, 7th decade. So people say, oh, this is because of the advancing age and diabetes. So diabetes may be there, but these symptoms are not typical of diabetic neuropathy. And diabetic neuropathy, you will get a person complaining of the feet and the ankles having problem of tingling and numbness even while lying down. Here the person says that till the time I start walking, I am fine, but as I start walking, these symptoms start. And what are those symptoms? So those symptoms are pain in the lower limbs, heaviness in the legs, numbness and tingling in buttocks, thighs, calves and feet, numbness in perineum, genitalia and saddle anesthesia, urinary incontinence sometimes on walking. And sometimes if they don't stop in the way, then their feet give way, their legs give way and they fall. So these are the symptoms of a neurogenic claudication. And coming back to this slide, you can see this is in cross section. This is a normal spinal canal here, and you see small nerve roots. This is a canal which is showing very severe kind of compression. This is a very severe compression here. You can see this is a normal canal, and almost the canal is not seen here. Okay, so this is a pictorial description of this problem. Here the canal is of normal diameter, and as you come down, there is a compression on the spinal canal. This is spinal stenosis you are looking at. So Fairbiest was the person or scientist and doctor who first defined this. So he said neurogenic claudication is any symptom complex that is brought about by walking and relieved by rest. And this symptom complex includes pain, burning, paresthesias, tingling, bladder problems, and power loss in the lower limbs. People typically say that after walking for some time, there is heaviness, tingling, pain, and they have to stop. They have to terminate their walking exercise. And here you can see extreme canal stenosis. One has to intervene in these patients and decompress these canals. And sometimes if one has to decompress far laterally, then in addition one has to stabilize them with instrumentation. Now I come to another entity which is called as CAUDA equina syndrome. This can happen in severe cases of canal stenosis, or in acute setting in large disc prolapse, or sometimes with fractures entering the CAUDA equina. Now Cauda equina was the name given by this person, Henri Lazarier, in 1605. He's a French physician, and he called this area Cauda equina because on dissection this looks like horse's tail. So cauda means tail and equina is of course that of horse. So this is called as Cauda equina, and this name has stuck till today. So the problem of Cauda equina is called as Cauda equina syndrome. And in this you get what is typically known as saddle anesthesia or numbness in the saddle area. So this includes three or more of these. So severe low back pain, saddle anesthesia, weakness, heaviness in the legs, urinary retention, fecal incontinence, and sexual dysfunction. So this is a conglomerate of symptoms which constitute Cauda equina syndrome. And it is important to identify this because it has been found that in chronic setting, this syndrome is missed because people again think that the urinary retention is because of old age or because of prostate, and the leg symptoms are, unrelated to urinary problem. And not only in our country, but even in Western world, the history of sexual dysfunction is not asked, and neither does the patient, tell the history properly. So it is important to identify Cauda equina syndrome because it is a neurosurgical emergency. If in acute setting, if you don't decompress this rapidly, then some of the nerves can die permanently. And one has to remember Cauda equina syndrome for this very reason, and act rapidly, examine properly, and then, perform investigations, that is X-rays and MRIs, and then immediately, as soon as possible, decompress this canal. Now, spondylolisthesis is another term that one has to know. In this, one vertebra slips over another. And this happens because of various reasons. The common causes are congenitally, there is a weakness in the posterior elements of the spine, and this causes the slip. Sometimes this can happen in trauma, sometimes due to a chronic and severe spondylotic process or fractures which happen here. But in the end, one vertebra slips over another. And especially this slip increases when the person sits or stands up and starts walking, and it reduces in the lying down position. So as you can see in this X-ray, this is the upper border of the lower vertebra here. And this is the L5 vertebra in which you can see this vertebra slip forward. You can see this slip very carefully. This is grade 1, grade 2, grade 3, grade 4. So this is approximately grade 2 slip here. And this is the MRI showing grade 1 slip. One has to remember that in lying down position, sometimes you can miss listhesis. And if you're suspecting it, then you have to do X-rays in standing position. So for this kind of a problem, the instrumentation that we used to use 20 years back was what was called as screws and plates. They were relatively big. As you can see here, this was a person I operated more than 17 years back, and this steel screws and plates have been used. And these are old implants. And now, of course, the person can, because we have put the implant and fixed the person, they are allowed to walk almost immediately. That is the next day after surgery. Now, the instrumentations have changed. We have got low caliber in size kind of rods of titanium, and there are cages of different types which can be used as spacers and fusion materials between the two vertebral bodies. So this is an example of modern instrumentation for spondylolisthesis. And this is shown on a rubber model. This is the titanium rod, and these are the screws which have gone inside the vertebra. And here you can see the cage. and this is a X-ray counterpart of this. Again, you can see there is a slip of the vertebra here, and this is after correction and putting a cage and performing the fusion. This is again an example of fixation with modern instrumentation. These modern instrumentation should be used judiciously, but when they are required, they are a great boon because these people get the support they need from within rather than using it from outside. And in fact, they can do many physical activities after this kind of fixation. So again, this is an example of how you have to perform flexion and extension X-rays, because some listheses get reduced in extension, but when one is asked to bend forward, that is flex, then you can see the listhesis increasing here. So importance of doing X-rays in standing position and in extended back and flexed back. Again, another example of listhesis and fixation. So listhesis can also cause severe stenosis. So listhesis can present only with severe back pain or with sciatica or with canal stenosis, or even with, in extreme cases, it can present with CAUDA EQUINA syndrome. So it depends on how bad the listhesis is and at what level it has happened. Sometimes the vertebra slips behind, and it is called as retrolisthesis in such conditions. And here you can see there is a disc prolapse, but this vertebra has slipped back rather than forward. So this is also not good thing, and it needs fixation. After removal of the disc, of course, you can see a huge disc fragment which had come out and was compressing the nerves very severely. So these are the modern, instrumentation which are helping us and allowing early recovery and early ambulation in these people. And this has happened especially in last 10 to 15 years at rapid pace. So I stop here. Next time, like these things happen in lumbar spine, neck is another area which gets involved, and then one gets neck pain and stenosis and myelopathy. So it is also very important topic. Neck pain, very, very common symptom, and radiculopathy, where the pain comes in the upper limb, or myelopathy, which involves the whole body. These are important topics, and one needs to understand this topic very carefully, again, because these patients come to general practitioners commonly. And secondly, many of these symptoms overlap on other symptoms like diabetic neuropathy, or general weakness of old age, or some other medical problems. So one has to be able to differentiate between the cause of such symptoms, and to differentiate, one has to know about these causes in depth. So I will talk about neck pain and cervical myelopathy next time. So I stop here, and we can take one or two questions quickly if they are there.
Sir.
Yes.
Sir, I am Dr. Anburajan, sir.
Yeah.
Sir, how can we differentiate between this diabetic neuropathy and this neurological, this neuropathy due to this disc lesions?
See, diabetic neuropathy, typically the presentation is in the extremities, like it is typically described as glow and stocking problem. Because it is in the distribution of, if one wears gloves in the hands or wears stockings in the legs, that is the distribution. and there is tingling and numbness and pain, sometimes severe burning pain in the soles, and that happens even at rest. The distribution is not radiculopathic, it is down, there is a cutoff, a level, that is, they say that I get tingling numbness up to knees or half of thigh, below the half of thigh. So this is the first important differentiating feature. Second is, again, as I told you, these happen at rest. They are many times severely affected during night. They cannot sleep. So people with spinal stenosis and neurogenic claudication till the last stage do not have pain while lying down. So this is exactly the opposite of diabetic neuropathy.
One more observation from our patients, sir. So usually this neurological pain, they say more in the night.
Correct.
While they are doing work, they don't get it. And then after going to sleep, they get it much. What is the reason, sir? Is there anything behind that, or it's only a perception?
No, it is a perception difference mainly. And there are, while a person is doing something, there are other sensations which are overriding those sensations. And also the attention of the mind is taken off from that area and, is focused on some other task. So that is why it is like, a train which is parked in a, yard, not being used. It is, just kept on the side. But at night, everything else stops and there is, focus that happens on the problem. And there are no sensory inputs from anywhere else. So that is a predominantly reason why it happens more at night, or it is perceived more at night, let's say. But even during day, if they are sitting quietly doing nothing, they complain of the problem.
Yes.
Sir, I have one question. Do these nerve conduction studies help in diagnosing or further diagnosing the sciatica or other these lower limb pains?
In nerve conduction studies for diagnosing sciatica are not useful at all. Clinical examination, MRI, and making sure that it is correlating with your clinical knowledge is the most important thing. But there are certain cases in which a person is diabetic and also has sciatica. So you are not sure which is more or which is which. So in such mixed pictures, these studies just help you to give idea. I have seen some people, I know the purpose behind this question, because we see some people advising nerve conduction studies before this surgery, and they're not useful at all. They're not useful. Nerve conduction studies are utilized when you are in doubt of the diagnosis. You don't know why the diagnosis, the pain is there. Or you are seriously considering a peripheral nerve entrapment rather than, disc problem. And you are finding it clinically difficult to differentiate between the two. Then these are so in very specific conditions, they are useful.
CAUDA EQUINA syndrome, sir. Probably we have to go for surgery, no?
Which one?
CAUDA EQUINA syndrome.
CAUDA EQUINA syndrome, yes. CAUDA EQUINA syndrome because
What
of
is the percentage of success in that, sir?
So the percentage of success depends on how rapidly one acts. That is very important because again, CAUDA EQUINA syndrome can be acute or it can be chronic. Chronic means not too long. CAUDA EQUINA syndrome, usually, I have seen CAUDA EQUINA syndrome occurring against the backdrop of canal stenosis. So the person has canal stenosis for a long time. He has neurogenic claudication, but he is able to walk for 1 kilometer. So he is not bothered initially. And even in such cases, we say that we can wait for some time. But in such a person, if there is a disc prolapse, then it is like adding oil to a fire. So fuel to a fire, and then suddenly there is compression, which is 100 times than before. And then these patients come with the complaints of severe back pain and buttock pain and numbness, saddle anesthesia, urinary retention. So in such cases, sometimes foot drop, bilateral foot drop is a presentation. So, it is very important not to let too much time pass on a foot drop or a neurogenic retention, and immediately, do the MRI or X-ray or whatever studies are required, and intervene first and remove the compression on the nerves. So it is like, when the tree, if it becomes, it is not watered for some time, then it becomes black. And then it cannot have leaves again. But there is some time in between wherein when it starts becoming black, if you water the tree, the leaves can again start coming. So after some time, even if you water the tree, the leaves are not going to come. So this time is very important. So the nerves are like tree, and they are dying every minute. So one has to be really fast in such cases. If there is a person with chronic sciatica, and if he wants to wait, it doesn't matter too much. But in CAUDA equina syndrome, you should not wait.
Sir, we have seen that in many patients, when there is sciatica for a long time, you can say chronic sciatica, many of the times we have seen that the patient is given along with some muscle relaxant and some anti-inflammatory drugs. He's advised exercise of the spine or maybe the back. What do you think? In such pain, the rest is important, or the exercise during the painful stage? What is your opinion, sir?
You're asking in acute stage or chronic stage?
Both. We have seen both types of things advised by many of the senior consultants.
No, acute case of sciatica, you should wait till the pain subsides, because it's very essential that the causative inflammation should not be exacerbated with exercises. After the pain subsides, it is important to visit again to the MRI and look at the MRI again and see why this pain came in the first place. So if the sciatica is because of gutter stenosis, as I told you, lateral gutter stenosis, then the exercise regime is very different. Like it has to be flexion based. In disc prolapse, it has to be extension based. So, it has to be a rational exercise regime. That is very important. And this exercise regime has to be tailored to every person. And that has to be a scientific process to it. Because I also see many people who are advising exercises, they just, tell people that MRI is not required. Sometimes I've seen people, some of these people throw MRI away. And they, tell people that they are not important. And exercise can be helpful, but they have to be tailored to each and every situation. So there aren't any universal exercises. Like people draw small dolls, on paper and just stick them and tell people to do this. This is not correct. One has to know why the pain is there, what is the pain generator, and the exercise regime has to be tailored to that person. Otherwise, the person will come back with exacerbated pain. I have seen this many a times. People come and tell me that I do these exercises and my pain has increased. That is because the pain was because of canal stenosis and they were doing extension-based exercises. So it exacerbated the pain. So this can happen. Exercises are important, but the person who administers them should understand the subject very clearly.
Sir.
What is the role of this supporting therapy in sciatica, like using the lumbar belt or giving these short wave diathermy or interferon treatment. So
they can be temporarily useful. They can be temporarily useful because you will see that the acute disc prolapse, many of these can, reduce, the pain can reduce over the period of time. So this is a therapy that is advocated in acute stage unless there is a, loss of motor function or involvement of bladder in acute stage, or the pain is so severe that the person is unable to bear it. Then we all give over-the-counter analgesics, anti-inflammatories, and diathermies in initial 10 to 15 days at least, and then see in what direction this particular disc problem is going, because every disc problem goes in a different direction. There is no definite rule to it, though there is a generalization of a rule, but the outcome of such patients can surprise you sometimes. So it is a sure shot Waterloo at times for the clinicians, because you tell someone and you believe while telling that you do surgery immediately, otherwise there will be a problem, and this person comes after 20 days and tells you, look here, I did nothing and I'm fine. And on the other hand, you tell someone it is not required and he worsens rapidly. So it entirely depends on that person's anatomy of the spinal canal and how the disc has migrated and how the root is compressed, because that is not apparent on MRI. MRI just shows you where the disc is and how it has herniated. So there are multiple variables in these people. So if one is treating them conservatively, one has to very carefully keep a watch on the neurological function. And if one is doing that, then there is no harm doing all these things. They can be helpful. Actually, the thing that helps in the end is time. Time is the thing that helps, because the portion of the disc that comes out over the period of time loses its water content and shrivels up. That's how the sciatica reduces. So it is a time that is required. So that time, pain during that time is treated by all these other things. So they are not going to treat the disc, but in between they are going to help the person bear the pain.
For the benefit of our CGP members, I would like to ask you one thing, that if a patient is to be referred for exercises, we observe that there are many non-qualified people and institutes, you must be knowing, but giving some exercise, some fantastic exercise for backache and this thing. They really, sometimes they are very brutal. But is it rather we should refer it to a qualified physiotherapist?
There is no doubt about it. But I see thousands of centers coming. We can't change what is happening. It is because back pain is so common, it has become business for many people, and the rationality is lost in that completely. So in the end, you say that let them go through all these cycles, let them spend some money, and spending money seems to give some insights to people. So you can't help these things.
We find there are so many videos on YouTube. People refer it to it. They do those exercises, like they do some yogasana and all that. And ultimately they land into trouble, and then they come to us and we have to refer it to
no, the reason is that in sciatica, especially disc prolapse, or a developing canal stenosis, in which way it will go is difficult to tell, even with scientific complete scientific thinking. It is difficult because it is like like we say that abdomen is a Pandora's box. So many things can come out from the diagnosis box. So it is the Waterloo for a diagnostician, abdomen. That's what it was. So similarly, the spinal problems can take different routes. It is our duty to keep a watch while, to diagnose the basic problem in the first place, and then keep a watch very carefully. The person has to be told that, look here, though you are being treated conservatively, one has to keep a very close watch on the neurological function and how it is progressing or not progressing. So all these therapies, what they make use of is that some of the spinal problems, reduce with time, nothing else. Time is the medicine. And so they say that, many people say that the spinal problems are treated with, electricity or magnets or so many scientific sounding things.
Yeah.
But it is true that these problems can take different routes. That is something which we have to remember.
So, Dr. Amburajan, we can now conclude.
Yes. As such, as it was done last week, so it's a very clear and very simple narrative, and it was very interesting, as well as I have to appreciate the the photos and this MRI pictures you have selected. They are very typical, and we were able to even appreciate it very well. Most of the time for us general practitioners, everything seems to be same, and we go by the reports given by the radiologists. But you have selected the pictures in such a way that we can understand that and learn that. So hereafter our eyes will be searching for something else, not a routine one. So
Correct.
you have come down to our level, and it's very much appreciable, and we appreciate you, sir.
Thank you.
You must have taken a much pain in explaining to this level. So then may God bless your practice and make you useful to so many doctors like us.
Thank you, sir. Thank you.
All over the world. Okay. So we had a very interesting this day today also. Definitely next week we'll have this neck pain, cervical spondylosis also clearing out a lot of our doubts. Sir, one more request. With a request, we want to conclude today's. During this course of your talk, some 5 to 10 minutes hypoxic damage of brain. Will you be able to hypoxic damage of brain? So about that, if you are able to tell any of the days, that will be of much use.
We can add it as a 9th lecture if you want.
No, there is a lecture on blood pressure and brain. So in that, I also want to discuss about many small topics together in one lecture. So I will devote some time on hypoxic damage.
Okay, thank you, sir.
Okay.
Thank you. We thank our Dean, Dr. Avinash Pandey. So he's after he has taken his video, a lot of this eye-opening to the general practitioners have been given, and it is his speciality to opening the eyes of our general practitioners. Let this task continue.
Thank you.
I have to thank all the our secretary, Dr. C. Anbarasu sir, and Joint Secretary Dr. Rekha Madam, and all others who have been our CGP office bearers, taking a lot of efforts to bring to its real shape of our team's enthusiasm and vision, whatever he is giving to us. And we have to thank the Synapse Brain and Spine Foundation also for their good efforts in bringing such a good topics to doctors to learn more. And we have to thank our IMA President, Dr. Prasad Singh, and Dr. Jace Lele, our Honorary Secretary General, who are very much encouraging to us in doing this kind of educational activities a lot. And then I have to thank all those who have attended today. Really, they are being blessed by a very good lecture, and they will never forget in their life these pictures and then explanation. So until we see for the next session on 27th May, the same time, 9 o'clock to 10 o'clock, neck pain and cervical spondylosis. Let peace be with you all. Thank you all. Thank you. God bless you all.
Good night. Good night. Good night.